Thanks to MSD's Health Champions or corporate sponsors who have supported making this podcast a reality. That's Peak Technology Associates, Delaware Healthcare Information Network, WSFS, as well as SourcePass.
Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasotto. I'm the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. This is our second season. In our first season, we did 37 very good, in my opinion, podcasts and very interesting for both the medical and non-medical community. This is our season 2. And today we will be talking about ADD and ADHD. I will introduce my guests shortly, but let's talk about a little brief introduction. ADD, attention deficit disorder, is an old term and is referred to people who have inattention without hyperactivity. ADHD is a neurodevelopmental disorder that affects attention, impulse control, and executive functioning beginning in childhood, but may even persist into adulthood. It is not a character flaw or laziness or lack of intelligence. So, I will introduce our guest, Dr. Saurabh Gupta. Dr. Gupta is board certified in the American Board of Psychiatry and Neurology. He is also board certified in the American Board of Child and Adolescent Psychiatry. He was chief resident in psychiatry at MSP Hahnemann University Medical College of Pennsylvania and Hahnemann University. He was then their residency in the same institution, which he did that for 4 years. And he was a fellow and is a fellow in the child and adolescent psychiatry from Brown University in Rhode Island. He was also been the medical director at Rockford Center, an acute inpatient psychiatric hospital in Wilmington, Delaware, for the past 17 years, and treats primarily inpatient child and adolescent patients. He also has his own outpatient practice in Wilmington, focusing primarily on child and adolescent populations. He also has been part of the Delaware Child and Adolescent Psychiatry Access Primary Care Initiative, which focuses on collaboration between pediatricians and child psychologists in the state, providing quicker access and support to pediatricians by the child psychiatrist in the state. Welcome, Dr. Gupta.
Thank you, Nick.
Saurabh, tell me a little bit about the history of ADHD and ADHD.
Well, that's a great question to start with, because over the period of years, ADHD has gone through so many transformations. But interestingly, if you were to look back at the history, the first documented medical documentation that you can find about ADHD was in 1798, when a Scottish physician by the name of Alexander Crichton was writing a book about mental health disorders. And he made reference for about 2 patients with ADHD and classically how they look like. But then fast forward to 1844, when there was a famous Swiss physician by the name of Hoffman who wrote about his son, and he called him Fidgety Phil. And a Fidgety Phil is exactly what you would think about an ADHD kid, somebody who is hyperactive, who's not able to sit still, and who's having a lot of issues with attention. And then we move on to the 1930s, when they found that people who had post-encephalitis syndromes, like infections of the brain, and they had some issues with the frontal part of the brain, were presenting with symptoms with very significant hyperactivity, impulsivity. So for a long time, it was actually called minimal brain dysfunction. Mm-hmm. So in 1968, so an American Psychiatry Association has a classification system called the DSM. And they actually used to classify what we now call ADHD under the classification of MBD, or minimal brain dysfunction. Now, over the period of years, like DSM-3 in 1980 was the first time that they used the term ADHD. And since then, DSM-3R and 4 and 5 are about to come. And they have been able to differentiate and say, okay, we have the basic core symptoms of inattention, hyperactivity, and impulsivity. Initially, they would classify them as kids who have combined type, which is the most common type, or you could have people who are predominantly hyperactive and impulsive, or you would have people who are predominantly inattentive.
Okay.
And that has helped us a lot in trying to come to terms and understanding what this syndrome looks like.
So in the neurological developmental abnormalities that these individuals have, it incorporates both norepinephrine, dopamine, and serotonin. And when you put it in a Venn diagram and all three circles come together, the one with ADHD seems to have all characteristics or involvement in those particular pathways. Is that correct?
That is true, and for a long time that was a hypothesis.
Okay.
And that's the basis on which they were using medication, saying that this is a hypothesis and this is how most likely it is happening. But as you're aware, Nick, over the last 20 years there has been such a huge advancement in neuroimaging studies and functional studies, so they've actually shown that primarily the prefrontal cortex and the basal ganglia are the regions where we see these deficiencies.
Got it.
And that is how the concept of using medications which help the neurotransmitters and correct the balance treats the condition.
As you know, I'm a primary care physician, so I see this quite often. A mother brings a child in, the child won't sit still, the mother's very upset, sometimes to the point of having to treat her for depression because she can't handle this child. Now, how does it usually present? Can you tell me, that child sitting in my office, what would it present like to me, and what would the mother tell me how it presents to her?
That would be a great question in terms of the child who is coming in with the hyperactive kid. Chances are that that kid is at home initially as he's growing up, and the mother, if she does not have any other siblings, would say, this is on the hyper side, he just doesn't listen to me. And growing up in the 40s, 50s, and 60s, people would say, he's just a rambunctious kid, let him be, let's leave him alone. And then as he would start going to maybe preschool or the school, the teachers would be calling and saying, your child is not sitting still, he's not paying attention, do something about it. And now with obviously increasing awareness of the condition, people are now saying, okay, now maybe he has ADHD, should we consult somebody or should we do something screening? But then if you also look at somebody who is an inattentive daydreamer kind of a thing, and we can talk a little bit more about that condition later, it could present very differently.
Mm-hmm.
The third thing which I think would be important to point is that you could have ADHD symptoms but they are not recognized, and you might be recognized as an ADD person when you're an adult.
Mm-hmm.
So it's a condition which transgresses the whole span of life. Now, diagnostically, you should have some symptoms present before the age of 12, but then it's quite possible that you're not diagnosed till you are in your 30s and 40s. And I have seen so many parents with their kids, and then they come in and they say, oh, I wish I was diagnosed with this when I was in middle school. I would have been the CEO of this company by now. So it's a dramatic change.
There is. I've seen in my personal practice beginning treatment with them, and watching a child who hasn't been doing well in school with maybe D's or F's go up to A's and B's, and the parents are elated. They love it. And seeing the child controlled better, less impulsivity, they seem to enjoy that, and they do not want to stop the medication.
Right.
Except for certain regions, which we'll talk about later. Okay, so you see a child fidgeting, excessively talking, interrupting, acting out, throwing things around, running around the office, and the mother says he just lacks focus, he's forgetful, and he does stuff impulsively for no good reason. That typically is what we see, correct?
That is what the initial presentation would be for a very hyperactive child.
Okay.
And the real question as a professional would be now to delineate this and say, okay, is it really ADHD or is there something else going on? Because every child who is hyperactive and impulsive does not have ADHD.
Got it.
So we do have what are called the diagnostic criteria for ADHD, and usually we use DSM-4 here in the US, and the criteria usually are that there are 12 criteria, and you have to go through each criteria and try to see if the child meets the criteria and how many of these are actually there. The second thing which is most important is that you have to observe or get some data from at least two different settings. A child could be very comfortable at home and is hyperactive, but then at school he is totally good, paying attention and first in class, not having any issues with his behaviors at all. Then you wonder whether something else is going on at home. Is it anxiety? Is it aggression? Is it something else in the parent-child interactions which is causing this, or some sibling issues going on? So one of the diagnostic criteria also is to have data from two different settings. Now, for children, we could use many tools. One of the tools which I commonly use is you can go to what we call Dr. Google nowadays and type in the word Vanderbilt ADHD rating scale. It's a free scale named after the University of Vanderbilt. There's a parent version and there's a teacher version. So I usually tell the parent, just print them out, do the parent version, and if you have children living in two different households, two different parents, have each parent fill it out independently, and then send out a teacher version to all the teachers.
Can you give me that again? Vanderbilt what?
Vanderbilt ADHD rating scale. And then there is a parent version and there's a teacher version. And the reason I said that is because this one is free and online. There are also many other scales which are proprietary based, like Connor's rating scale is used a lot, and there are some many other scales. But for a average normal initial assessment, I would say just start with the Vanderbilts, talk to the teacher, get input from 2 or 3 different settings, and then you have to see that we are seeing this impulsivity and attention span issues across different spectrums. Now, the question which also says is, what do we do if we have a 19-year-old or a 25-year-old saying, I think I have ADHD, what should I do? How do I get assessed now? Because all through my school I was able to wing it, and now I'm here working, but I think I cannot pay attention. So there's actually another free scale which is used, which is called an adult ADHD rating scale. And that would be a good starting screening scale for adults. Again, it is free. You can just go online and print it out. It usually has about 18 questions, and you go through them and then get some collateral information. If you are married, I'll talk to your spouse. If you are living with your friends, or if you're living with your parents, it's always nice to have more eyes, more information, and then decide what makes more sense.
Okay. That sort of leads us into our next question, even though we may have touched on it earlier. How does ADHD affect children, and if it continues into adulthood, how does it affect the adult? Now, I'll let you go with the children first, then we'll move into the adults. Give me all those symptoms you think you'd see.
So a classical child who has ADHD would present either very hyperactive or he will be inattentive. Typically in the younger age group, we would see children who are unable to sit still, unable to sustain their attention. Sometimes, though, you might say the parent will say if he's playing video games, he can play for hours. But then when he's doing his studies or other things, he's not able to pay attention.
How is that? How is that they could concentrate on one thing that interests them and then not have any interest, or they can't pay attention to others?
So they do have what's called selective attention, but at the same time, if in that video game you were to put in a criteria of saying that if you see, for example, this is what they use in a test called a TOVA test or CPT test, is if you tell them to click every time they see a red bird, their scores will not be good, even though it's like a video game. Okay. So there are actually nowadays some video game tests which have come out that parents can pay for, and you can diagnose ADHD because they can do that test online. But typically in a classroom setting, a younger kid would be, he's getting into fights, he's not listening, he's not paying attention, he's making careless mistakes, he's rushing through his homework, and then his assignments are not turned in. Parents have spent 2 hours doing their homework last night. He has the homework in the folder. If he remembers it, or if his parents put it in his folder, but then he's the one who's supposed to turn it in and he forgot to do that. And that's usually when the grades start sliding. His friends are not willing to sit with him because he's angry all the time. He wants things his way because he has a low frustration tolerance. Your hyperactive mind wants to be, why can't you keep up with me? My mind is racing. I'm living at 100 miles an hour. Why are you so slow? And that's when I get angry. So typically what you see with an ADHD kid is not only the hyperactivity, but the irritability, the aggression, because that's coming with low frustration tolerance.
Got it.
And then the third point which will come into that is then nobody's my friend, nobody likes me, and then I'm getting depressed. So there's a whole plethora of not only just ADHD, but I think what is missed is that there are so many comorbid issues there.
Mm-hmm.
And comorbidity is one thing which people don't think of when they think of ADHD. So it is just one of the things, but then there are so many other symptoms, so the proper assessment is most important.
So nobody likes me. They can't really get along with other kids and their other peers in their classes. Is that what that nobody likes me is about? Why don't they like them? Because you just can't sit
Because
still.
my mind is so fast and I want to do things right now, and before I'm finishing up with one project or talking to you, I've already moved on to Joe here, and then I moved on to Nick there, and so
Gotcha.
nobody is like, okay, you're not paying enough attention or you're not following through. The follow through is not there.
Okay.
And typically what you would say is that this is an intelligent child, but he just cannot finish a project.
Mm-hmm.
He starts a project and then he does not finish it and moves on to something else,
Mm-hmm.
which is very classical in ADHD also.
Got it. Well, now we're moving on to adulthood. This is the typical guy that can't keep a job, can't concentrate, he's inattentive, he's unstable in his life altogether, right? Tell me about the adult.
So usually the adults come in at different stages of their lives, and a lot of time what I have seen and what you read about is they become aware of it when they see a younger child or somebody else going through what they think is ADHD, or they are in the room having their child being assessed and say, oh, wait a minute, these are my symptoms too. Like, I'm good at my job, I'm very smart, but then every time my boss gives me something to do, before I am completely done, I've already moved on to something else, or I'm making some careless mistakes.
Or he's procrastinating about his job.
Right. Or he's procrastinating about making decisions. Or I get very agitated very easily, and then the anxiety comes in because then I think I'm not good enough. Am I doing something wrong? When actually I'm not able to pay attention, and then now I realize what I'm doing. The third thing which you often see more in girls and women is daydreaming. There's a lot of daydreaming involved. In terms, you don't see the classic hyperactive person, but you see the daydreamer. And you might be talking to them, but their mind is already thinking, what am I going to do tonight after I leave this office? Or what am I going to do about it? And then the anxiety comes in. There's a lot of literature about an overlap of anxiety and ADD symptoms, especially in younger women and adolescent girls.
Interesting. Is there any promiscuity that comes with that? In other words, are they hyper in some other areas?
So that actually again goes into the comorbidity. ADHD, the impulsivity alone may not be causing the promiscuity part of it, but if somebody has, say, an associated bipolar illness or something else, then they are making choices which are not correct.
Got it.
Then ADHD person is mostly quite smart. Like a lot of old misnomer was, if you have ADHD, you're not the smart kid. You're not the smartest kid, but that's not true. ADHD has nothing to do with your IQ or intelligence quotient. You could be most people who have ADHD actually are quite smart.
I was told that a controlled ADH is very good to hire.
That is true.
Because they can do a lot of things for you, and they do them if it's controlled, okay?
Yes.
That's what I think. Tell me a little about the genetics of the condition. Does it come from the father's side, the mother's side, both sides? What's its...
So we are lucky nowadays that we have so many studies which show that there is a very strong genetic predominance in that. Now, as a general rule of thumb, you could say that if both the parents have ADHD, 25% of the children are definitely going to have ADHD. The ratio between boys and girls is usually seen as 3:1.
Boys to
general,
girls.
Boys to girls.
Mm-hmm.
Now, they also did a lot of twin studies. As you know, nowadays there are a lot of data about monozygotic twin studies, and the concordance rate of monozygotic twins is about 77%, which means that if we have two twins who have exactly the same genes, if one twin has it, the second twin, the chances of him having is at least 70%.
Wow.
If it's a dizygotic twin, the rate becomes about 8%, and if it's just a sibling and with nothing, it's about 8%. So there's a very strong genetic component to ADHD, and again, that's only been possible nowadays because people have been able to do all these studies, and we have some good registers for that.
Got it. I'd like to take a break right now. We will be back with Dr. Gupta after our break, but I'd like to just bring your attention to the fact that if you have any questions, any comments, or even some ideas for future podcasts, check us out on our website, healthcare.reality at medsocdel.org. That's healthcare.reality at medsocdel.org. And we'll be back shortly.
A special thank you to SourcePass for sponsoring today's podcast. Healthcare organizations face immense pressure, ranging from aging IT infrastructure to complex data privacy laws. SourcePass provides healthcare-focused IT solutions designed to overcome these hurdles, enabling you to deliver high-quality patient care with confidence. SourcePass is transforming how businesses experience IT. As your managed service provider, MSP, SourcePass delivers far more than tech support. SourcePass helps all their clients align their technology with their business goals to best mitigate risks while unlocking new levels of efficiency. Whether you're a fast-growing startup or a well-established practice, SourcePass provides the expertise, scalability, and human touch to help you thrive in a digital-first world. Whether you're located in Wilmington, Dover, Newark, Middletown, or Rehoboth Beach, SourcePass local teams are ready to support your success with flexible, secure, and business-aligned IT solutions. A proud corporate sponsor of the Medical Society of Delaware, learn more about why SourcePass is the best choice as your IT partner at www.sourcepass.com. SourcePass, excellent service, strategic guidance, delivered with innovation.
Well, we're back from our break now, and I'd like to repeat a thanks to MSD's Health Champions, or corporate sponsors who have supported making this podcast a reality. That's Peak Technology Associates, Delaware Healthcare Information Network, WSFS, as well as SourcePass. We talked about the diagnosis. We talked about how they act both in childhood, adolescence, and in adults. Now let's talk a little bit about the treatment. And tell me, historically, you told me earlier before we started this podcast that a certain doctor decided to try a stimulant on kids that were off the wall.
Right, and that's a very interesting story. There was actually a Dr. Bradley in Rhode Island who in 1937 used stimulants on about, I think it was 20 children who were very hyper. I think he was using it for some other purpose, but paradoxically he realized that all these children were calm. And there are quotes about it, and they say, wow, this works for ADHD. They were not really sure why it was working at that time. Mm-hmm. This was all based on a hypothesis. Interestingly, Dr. Bradley, then later, there's a hospital now in Rhode Island where I was a fellow, and the child psychiatry, the program, the hospital is called Bradley Hospital. It was named after him.
Wow, how do you like that?
The other interesting thing which I think you would find interesting, our audience could find very interesting, is that we all know about the word Ritalin. Mm-hmm. And we say, oh, everybody on ADHD is on Ritalin. Mm-hmm. But actually, there was a chemist, I think it was 1944, he was a Swiss chemist. He actually developed the salt methylphenidate. His name was Leonardo Panizion, and he made this chemical, and his wife took it, and her tennis game improved. His wife's name was Ritalin, so he actually named the medication as Ritalin in the honor of his wife Ritalin. I'm not sure how many people are aware of this, but that is how the methylphenidate, which is one of the salts, came to be known as Ritalin.
Very interesting. Well, that's methylphenidate. That's Ritalin, and then we have Concerta, which is a longer-acting Ritalin, correct?
So let me take a step back and let's do a basic 101 about the treatment options for ADHD, right? Mm-hmm. The way I would explain is that we can go with medications, or we could have non-medication treatments also. Behavior modifications, cognitive behavior therapy. There are so many other techniques. So everybody with ADHD does not need to be on medications. Usually medication is the last resort.
Really?
I would say that if you have a child who comes in with ADHD or an adult who comes with ADHD, I would encourage that let's look into what are the things that you can change. For example, what could a child change in school if he has difficulties paying attention? We could tell the child that you need to sit in the front. We need to tell the child that you need to stay away from other kids. We can tell the teachers, give the homework, give them in small increments, or give them small directions so they don't get ahead of themselves.
Mm-hmm.
Nowadays, this is all under the part of what we call the individualized education plans for children, or IEPs or 504 plans. Those are very good approaches which help the child behaviorally, and they kind of give him a positive reinforcement and a sense of mastery of that I can do this. We also follow what is called the biopsychosocial model, which was proposed by Engel in the 1960s, which means that most of what our illnesses are always have a biological component, psychological component, and a social component. And no treatment is perfect unless you try all three. And there have been studies which have actually shown beyond doubt that you have to have a combination of all three. Coming to the biological aspect of medication, if we say, okay, let's start with the medication. So there are two kinds of options.
To interrupt just a second.
Sure.
How do we deal with those changes? In other words, cognitive behavioral therapy, who does that around here, and where can we get that taken care of so he could sit down and maybe through some cognitive changes or behavioral changes he can use no medication and do well?
Right, and that's a very good concept. And actually, cognitive behavior therapy was started right here in Philadelphia by Dr. Beck in Philadelphia, and there's actually a Beck Institute on Route 1 in Philadelphia. And the concept is that when we are thinking about any thought process and our behaviors are related to the thought process, how can we change that? And then there are actually, you can have workbooks and worksheets. So children and adults are given homework. Now, CBT has been found to be very, very effective in depression and anxiety, but also there's a whole section for CBT for ADHD.
Well, in this area, where can they get that kind of therapy?
I would say the best would be to just Google cognitive behavior therapist near me for ADHD.
Got it. That's an easy way. Sounds good. Our audience will like that if they have kids that need some behavioral changes. That's very good. I fully understand that and appreciate it. Well, we talked about the stimulant methylphenidate. Now, the bigger one out there and very difficult to get is the amphetamines. For example, Adderall. Trying to get Adderall in this town is very difficult. It's back ordered. Nobody has it. Patients that need it going around in circles trying to find it. And the longer-acting Adderall, which is like a Adderall, is like Vyvanse.
So, essentially, there are stimulants and non-stimulants. The way we describe medications for ADHD are there's a stimulant category and a non-stimulant category. Amongst the stimulant category, we have two basic salts. One is the methylphenidate and one is amphetamine. The amphetamine salts are what you are talking about in terms of Adderall and Vyvanse, and we'll come to that in a minute. And the methylphenidate salts is everything else, which is like the most common we talked about, Ritalin. So the two stimulants are only these two. They come in different formulations, and the race amongst all companies nowadays is what is the drug delivery system. We have short-acting stimulants, we have intermediate-acting stimulants, and long-acting stimulants, which means that we take a medication, it's going to last for about 4 hours, and the medication wears off. Then we have a medication, what are called the extended-release ones, which last for about 8 hours, and then they wear off. Then we have some which are called more extended release, like the Vyvanse and Mydeas, which are about 12 hours. Now we also have formulations, you actually take the medication at night, and the capsule is actually coated with a digestive enzyme which dissolves in the morning, and then the beads are released, so when the child or adult wakes up, the active constant is being released at that time.
What are those called?
It's called Jornay. There's only one, Jornay, and that's a capsule which you give at night. And basically, it's all about the drug delivery system nowadays. So the capsule is taken at night, and the rationale is that when you wake up, you have a hyperactive child or a hyperactive person, By the time you take any medication, it kicks in. By that time, you've already had a bad start to the day. So if you think about it, this makes complete sense. You wake up in the morning, the salt is being released in your body, and now you already wake up feeling calm. So there's a lot of good, interesting psychopharmacological interventions there. But then we also have effective non-stimulants. Atomoxetine and guanfacine are two of the commonly ones used. So it's important to understand why we use which.
Is that Strattera Intuitive?
Yes.
Okay.
And so the main difference...
in my experience in giving those, I did not have good results. Most of my patients came back and said, did nothing.
So it depends on who the patient is and which patient it is.
Mm-hmm.
They have been very effective. A lot of double-blind control studies have shown that they're really very effective. I personally have many patients on the non-stimulants who do great.
Mm-hmm.
Their parents who do not want their child on a stimulant because of their side effects like appetite suppression or sleep or the threshold for tics can go down. They prefer non-stimulants. And especially for the inattentive types, actually non-stimulants are much more effective.
Really?
Now, all studies show that whether we use a stimulant or a non-stimulant, they're definitely much better than a placebo.
Okay.
So
You can actually use both, correct?
you could use a combination of both.
Mm-hmm.
And the advantage of that is that then if you are a non-stimulant, you could then maybe use a slightly lower dose of a stimulant because they are complementing each other's effects.
No.
So it's a matter of like kind of working finely in terms of how do we make sure that they are not having enough side effects, but also the effectiveness is as good.
Got it. Also talk about clonidine, which is a antihypertensive medication, catapress, which is used, and I add it to those that are having sleep difficulties because it is sedating. So I seem to keep a patient on a stimulant or non-stimulant and adding clonidine if they have sleep disorders, because that can have some changes in their behavior also if they're sleep deprived.
So the way the clonidine works is it's an alpha agonist and it helps you go to sleep at night.
Mm-hmm.
But they also have an extended release of clonidine, which is usually very effective for younger children with hyperactivity. And it comes by the trade name of Capway. So it's all a matter of combining different medications to minimize the side effects and optimize your functioning.
Optimized sleep is very important, correct?
That is the most important thing.
Okay, is attention deficit disorder associated with other conditions? I think we touched on it earlier, the anxiety, the depression. But are there others that it is associated with?
So the most common comorbid disorders you see with ADHD is a lot of what are called the oppositional defiant disorders, conduct disorders. There are also a very high correlation with substance use disorders because these are the children who could also go into this. But again, comorbidity is just because, say, for example, if you have diabetes does not mean that you cannot have high blood pressure.
Correct.
Or just because you have a medical illness of one organ, you can still have it. And that's the same hypothesis applies here. You can have ADHD, but you have a higher chances of you being defiant. As you grow older, you can get into conduct disorder. You can have oppositional defiant disorder. You can have depression. You can have anxiety. And the propensity of substance use is definitely there, which interestingly then leads to when we have an adult who says, I have ADHD, most physicians would first say, oh, he must be a substance user because he's looking for Adderall. And the classical way to say that is, okay, I think you do have ADHD, but instead of a stimulant, I'll give you a non-stimulant. If the patient is willing to work with you on that, you know that yes, he's a genuine patient. Or if he says, no, only Adderall works for me, then you know that's a red flag.
And they also, in substance abuse individuals that go that route, are they trying to self-medicate?
So I don't think there is a blanket statement about that because people with substance use, as I said, had comorbid ADHD also. There could be people who genuinely have ADHD. And if we have a patient who is struggling with addiction and substance use, has ADHD, by not treating him, we are actually doing them a disservice. The key is to make sure that we correctly diagnose, identify, and then work with the patient, making sure that they are not diverting it.
Got it.
And that is important. There are many safe parameters there. Like if you are really assessing a patient properly, you're getting collateral information, you're talking to the family, you're engaging the patient. When, as prescriber, there's actually now in every state in the country, there's something called a prescription monitoring program or the PMP program. So it is mandatory, though it's still voluntary, that if you're prescribing a controlled substance, you should go on in Delaware it is called the Delaware PMP program. Anybody who's a prescriber can log in, make his own account, and that will give you the patient's all medication that he's been on. So if you see a patient has tried narcotics and stimulants and he has 6 different prescribers, then you know the red flags are there. So that's a great thing which has been there for the last few years now. ADHD is diagnosed as considered as a mental illness. Though some people talk about it being a neurodivergent illness, but again, if we go into the look at the definition of what is an illness is anything which is preventing you from functioning at your ideal social or occupational level. So if it is you're not able to function because you're not able to pay attention, it's like saying, if I have severe pain, I need something for pain medication and that helps me my pain, then I can function. Similarly, if I cannot pay attention, I'm too hyperactive, I'm procrastinating, and after I take my medication, I can work at my job completely, then that's an illness which has been treated. The other thing which we also in children also sometimes we didn't talk about is there's a comorbid learning disabilities like dyslexia, graphia, so many other challenges are there. And that's where the role of neuropsych testing can come in.
Got it.
Because some people would say that, okay, we have ADHD, should we get testing or not? And the usual response is that clinically you can diagnose ADHD as a clinical diagnosis, but the value of neuropsych testing would come if you want to see if he has a comorbid learning disability or some other educational challenges, which then the school can alter the curriculum accordingly.
Got it. Thank you. We touched on some of these earlier, but what are some of the strengths of a person who has ADHD, whether a child, adolescent, or adult? What are some of their strengths?
How the medication is working for you, how long it's lasting for, and then we can ask your parents and teachers about their observations, but you are the one who's aware of what the medicine does for you or not. And you'd be surprised when people come in and say, I could feel that I did this because I think my medication wore off or I forgot to take my medicine today.
Are these individuals more creative, more entrepreneurial thinking? I mean, these things I've read, it's what gave me hope with my children as they grew up with ADHD. These are some of their focuses and some of their strengths also, isn't it?
So from a purely double-blind, placebo-controlled studies-wise, I doubt that there were studies which would show that, but in general, the concept is that yes, they're very creative because they are all over the place. There are no limitations to how they're thinking, and they can do what they want to sometimes, and the creativity is definitely there.
And if they find their niche, they excel.
They do, and there's some people who would say, I like my hyperactivity, I don't want to medicate it. And then there are some schooling systems which actually promote that. They would say, okay, we don't want our children to sit in a desk and study. They can walk around, they can move around as long as they are doing their creativity and able to follow through with the course. There are many schools which I'm aware of which actually follow that pattern. And that is very good for the creativity for this child. Because treatment by medication, as I said, should only be the last resort, only when you feel that your functional strengths are being compromised or you're not able to function to the best of your knowledge.
They say that fewer than 30% of people who are medicated, either with stimulants or non-stimulants, find that they're not getting full benefits from their medications. Do we switch them? Do we up them? What do we do?
So we have to have a rational approach. We have to say, am I medicating the patient adequately at the right dose, and am I really monitoring that? Usually what you see is that the patient is being medicated at lower doses or inadequate treatment is being done, and that's when the patients are coming and saying, my medication is not working. The other thing is something called tachyphylaxis, is that if a patient is doing well on, say, 20 milligrams of an amphetamine, he could be doing very well for a few years, and then suddenly one day says it stopped working. And that's a known phenomena, and what you do is you change the salt and then the patient would respond better to that.
Interesting. I often wondered about that myself. Well, thank you. Do you have anything else? This has been a very interesting conversation. It hit home in my case and in my family and the like, and I have patients with this problem. Can you tell me, are you available? Can people get in touch with you? You have a private practice as well as working at Rockford. Is there any way we can get in touch with you or they can get in touch with you if need be?
Sure, absolutely. I have a website. It's called www.drguptamd.com, which is drguptamd.com.
Mm-hmm.
And I'll be happy to answer all questions. And I usually am very approachable by email.
Mm-hmm.
And I love working with these patients. And we could sit here for hours talking about these medications. And maybe we could take over all of your next year's podcast schedule.
It could very well be. Well, Dr. Gupta, it's been a pleasure having you here, and I've learned a lot, and I'm sure my listening audience has learned a lot. There have been certain things I will pursue now in my practice that I may not have used, such as that 12-step scale to figure out what type of condition this person has. I appreciate your coming. And I would like to somewhere offer you another visit to us on maybe a different subject.
Thank you very much for having me. I really appreciate it. Thank you.
Great. This is Dr. Nick Biasotto finishing our podcast with Dr. Saurabh Gupta. And again, anyone who has any questions, any comments, or would like to give us any subjects that we can talk about later podcast, please use our email, healthcare.reality@medsocdel.org. That's healthcare.reality@medsocdel.org. And this is Dr. Biasotto saying, till next time.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.